We've got a really exciting program for you today, but before we start, I'd like to just take a moment to acknowledge the traditional custodians of the lands on where we are meeting today, wherever you might be. I'd like to acknowledge any Aboriginal or Torres Strait Islander people who are also joining us today and pay respects to elders past, present and emerging. This is the third year that we've been running our forum on the online format, and we were really keen to do this live this year, but I can tell you that in 2024 we plan to run a live event because it's so good to be able to catch up with everybody face to face. We've actually got our two clinical directors, Z1 and Andrew Haydon, who are going to be hosting the event today. But there's been significant changes to SMICS, and over the last 12 months, there's been changes in where we report to from a governance point of view up through the Health Service Partnership CEOs. And we've also separated out our regular governance meetings from the Monash MPCC. So that's also been a big change with the group being able to focus just on SMICS work. And there's certainly been improved and greater relationship building as a result of that small change. Can I just also say, though, we haven't lost the MPCC group with a number of people sitting across both programs. But I don't want to take up too much time with the introductions because we have got a very full program. So I'm going to hand over to Andrew Haydon and let him introduce our speakers today. So thanks very much, Andrew.
So, thanks very much, Felicity. Good afternoon and welcome. My name's Andrew Haydon. I'm one of the clinical directors at SMICS, and I'm joined by my fellow clinical director Z1 Wong, and together we will share with you some of the great initiatives undertaken across the SMICS catchment. It is a very tight program today, but there'll be plenty of opportunities for audience members to interact with our speakers. We will be using Slido to ask questions, so please use the QR code, or you can link or click the link provided on your screen. So let's get started. First of all, let's find out a bit more about our audience online today. And the first poll question should appear on your screen now to let you decide what your role is. So I'll give you a few seconds to respond to this. All right. Well, thank you for responding. We've got a wide range of health practitioners here. But in the interest of time, I think I will now hand over to Z to introduce our first speakers. Over to you, Z.
Thanks very much, Andrew. I'm delighted to actually introduce the first talk, which will be jointly presented by our first two speakers. Dr. Olivia Cook is a registered nurse, educator and researcher with over 20 years of experience in the fields of women's health and oncology. Olivia joined McGrath Foundation in 2021 and is the head of the nurse education and research in McGrath Foundation nursing program. In her role, she is responsible for the education and professional development of 200 McGrath Breast Care Nurses located across Australia, which is amazing. Olivia's career goal is to ensure all Australians diagnosed with cancer have access to the care of a specialised cancer nurse when they need it. So Olivia will be presenting together with Gill Kruss, who works as a metastatic breast cancer nurse practitioner at Monash Health 3 days a week and is the chief clinical lead for education for the McGrath Foundation 2 days a week. Gill has a special interest in teaching Australian breast care nurses to provide optimal supportive care to those with metastatic breast cancer and is co-leading the implementation and research of a specialised national training program to upskill these nurses. Before we commence the presentation, Olivia and Gill are keen to seek some information from the audience today. So 2 poll questions will appear on your screen, and I'd like to give you a couple of seconds to respond. If we could have the poll questions on your screen, please. Thank you. Might just wait a couple of seconds for people to respond. So the first question, does your healthcare service provide care to patients with metastatic breast cancer? I think we have an overwhelming yes of more than 90%. And could we have the second response to the second question? Do you have a dedicated metastatic breast care nurse in your X region? We have up to 60% who answered yes, 23% unsure, and 17% says no. Thanks very much for your responses. Over to you, Olivia and Gill.
Welcome everyone. My partner in crime, Olivia Cook, and I thank SMICS for inviting us to speak to you today on the Metastatic Breast Cancer Nurse Training Program, an innovative, cost-effective program utilising telepresence robot technology to upskill Australian breast care nurses. And as you can see here, this has been a wonderfully collaborative project between Monash Health, McGrath Foundation, SMICS, and I've mentioned Monash Health twice, that has led to a big impact across Australia. And we'd like to make a special mention to the oncology team at Monash Health, who have generously shared their time and expertise with filming presentations and having nurses observe in their clinical consultations.
Thanks, Gail. It's more important than ever that we take this time to acknowledge the Bunurong and the Wurundjeri people of the Kulin Nation as the traditional owners and custodians of the lands on which this program is conducted, and we extend this acknowledgement and pay our respects to all Aboriginal and Torres Strait Islander people on this call today. Thanks, Gil. We have a couple of disclosures. So we have generously, McGrath Foundation, I should say, have generously received funding from Novartis and AstraZeneca to fund the robots and the development of the education modules. McGrath Foundation and SMICS have also provided some funding to Monash University for the evaluation of the program. But we'd especially like to thank SMICS for their very generous in-kind support of their team members, Heather Davis and Jessica Delaney's time over a 4-year period, which was very extended due to COVID lockdowns, but we appreciate the support for this project. Thank you.
So this is a little summary on the background of this project, and over the past decade there's been an identified supportive care gap for those with metastatic breast cancer, and currently across Australia we have 204 McGrath Foundation funded nurses, and we aim to get 250 by 2025. And 42 of these nurses are dedicated metastatic breast care nurses. And these 42 nurses come from differing backgrounds and levels of expertise. So there was a need to train these nurses to increase their knowledge, skills and confidence levels in metastatic breast cancer nursing. And so we developed this pilot project, which we titled at the time the Metastatic Breast Cancer Nurse Training Program. And we used a prepare, explore and apply design for the training program, whereby a bespoke training program was designed for each participant from a suite of 20 different modules relating to metastatic breast cancer nursing. And they were all online on the McGrath Foundation's portal. And the participants then spent 3 days observing in the clinical areas with the specialty clinicians at Monash Cancer Centre at Moorabbin Hospital. And then they were supported with 1 year clinical supervision by every second month to discuss any barriers or enablers with integrating what they'd learned at Monash Health or any challenging metastatic breast cancer cases that they may have encountered in their own workplaces. However, then a spanner was thrown in the works with COVID lockdowns in Victoria, and there was uncertainty whether we could get these interstate nurses across the borders into Victoria, let alone through the front doors of the hospital. And as you'll see on the next slide, this impacted on our aims and methods of running this pilot project.
Thanks, Gill. So we originally received Monash Health HREC approval to conduct the training program and evaluation in early 2020, but of course COVID prevented us from commencing it, and it wasn't until 2021 and several ethics amendments later that we're actually able to have our first nurses commence in the program. So we had a sample of 8 nurses completing the program as 4 intakes of 2 nurses. 6 participated by the robot and 2 in person, and they participated between August 2021 and the final clinical supervision sessions ended in June this year. So the aims of the program were to engage an expert working group to develop a curriculum of training modules in metastatic breast cancer nursing, from which, as Gill mentioned, those individualised training programs were designed. We evaluated learning through participant self-assessment using the validated cancer nurse self-assessment tools for metastatic breast cancer, which was also a secondary project to this one to design and validate those. We explored the expectations, goals and experiences of participants through qualitative interviews, and we explored the impact of the individualised training program at the service and national levels through McGrath Foundation activity data that's recorded by every nurse in the country. Originally, of course, we had planned that all participants would complete the practicum in person. However, due to COVID, we had to reimagine this program, how it could be delivered, and we invested in the 2 telepresence robots as a way of allowing nurses outside of Monash Health to enter the hospital. So with this, it's obviously a very novel approach to learning, and a 5th aim was added, and that was to explore learner, facilitator and clinicians' perceptions and experiences of robot-assisted learning compared with face-to-face learning. Thanks, Gill. If you don't know what a telepresence robot looks like, this is what it looks like, a little bit like an iPad on a Segway. So here's some pictures of us in the learning phases there. Thanks, Gill. And because none of us knew how to drive a robot, we all had to learn, and we incorporated robot driving lessons into the metastatic training program.
And through the training program, we were able to showcase, teach and promote to the participating nurses these best practices that we do with our metastatic breast cancer model at Monash Health, such as integrating supportive care screening into practice, teaching them how to improve their assessment skills to assess and manage patients' symptoms or side effects of treatment. And they also learnt how to set up ideal processes for monitoring patients on anti-cancer therapies, oral anti-cancer therapies. And best of all, the nurses were all able to see a metastatic breast cancer multidisciplinary team meeting that's unique to Monash in operation. And all the nurses got to present a case to everyone at this unique MDT of a newly diagnosed metastatic breast cancer patient.
So the results of the pilot have been overall very, very positive. So we found a statistically significant increase in the knowledge, skills and confidence at the 3 time points measured by the CANSATs, regardless of whether the nurses participated in the robot or in person. Participants felt like they were present at Monash Health even when participating via the robot, and they really valued the different components of the program, the online learning, the practicum, and then follow up with the clinical supervision. The results of the nurse activity data demonstrating the impact at the service level are still pending. That data collection period's only just finished now, so we're just in the process of analysing that data. The clinical supervision component was found to be really beneficial to participants, as you can see by that quote there. And overall, robot-assisted learning was found to be a really cost-effective method of upskilling breast care nurses that really overcomes those geographical barriers to learning. Thanks, Gill.
So in terms of current and future plans, this pilot was a collaborative project that extended beyond our SMICS catchment area and beyond Victorian borders to have national impact. It enabled Australian breast care nurses to observe the best practices and models of care of metastatic breast cancer patients at Monash Health. It aligned with an identified national need for qualified metastatic breast care nurses. And the learnings from the pilot project have helped inform the ongoing delivery of the metastatic breast cancer nurse education program. We've now renamed it. An ongoing partnership between Monash Health and McGrath Foundation has enabled a further 6 intakes of 12 metastatic breast care nurses from either Monash Health, Victoria, or from around Australia to participate beyond the pilot project, with plans for many more intakes in the future. And robot technology will continue to be used for educating nurses from those who are from interstate or from rural and remote areas. So we want to thank you again, SMICS, for your contribution to this project and for inviting us to speak today. And thank you to you all for your interest, and please reach out to Liv and I if you have any questions. Thank you.
Thanks, everyone.
Thanks very much, Gill and Olivia. Such an interesting, project and initiative. And now, before we go to the questions on Slido, there is a poll question that should come up on your screen. I think we're interested to find out from the audience participating today whether you would now consider using telepresence robots to help deliver education or training in clinical practice. I'll just give a few minutes for people to respond to that question. Right, we've got majority says yes, 76%, and 22% are sort of sitting on the fence, being unsure. And we have 2% who are maybe slightly more apprehensive. I'd like to go to the poll questions. Sorry, just bear with me. All right, we do have a few questions online. How are we doing with time? I think we have a little bit of time. We can ask a few questions. Now, the first one, one of the audience is interested to know the plan for continuing offering for this valuable training. And I think, Gill, in your presentation, in part, you've actually replied that. Perhaps if you want to expand that with a little bit more details, that would be wonderful. Sure. Yes. So we're continuing to have 4 intakes per year of 2 nurses per intake. And as I said, we've continued beyond the pilot project to deliver this and hope to continue doing this. We have plans to try and educate all of those metastatic breast cancer nurses. To answer the second question, are patients comfortable interacting with the robots? Surprisingly, yes. They generate so much interest, particularly when we do the robot driving practice. I have the nurses, I teach them how to get into the robot, and then we have a little drive around the hospital, and anyone walking past all want to stop and have a chat to the nurse who's in the robot and driving it from wherever they are in Australia. And last week we ran it and we had Mel from Western Australia in Perth. She was in the robot, which was a great effort because there was a 3-hour time difference. She got up at 5 o'clock in the morning to join the multidisciplinary team meeting. So it's just amazing. And I remember the first time we used it, I went on a ward round, on the palliative care ward round, and we had a patient there that was singing to the robot. He really enjoyed singing. And so he just broke out into song and interacted with the nurse who was in the robot. And same in the clinic. We always check with the patient whether they're comfortable with having a nurse observing in the clinical areas, and check that they're also comfortable with interacting a nurse who's inside the robot. And because the nurse can drive it, they feel like they're in control of the robot. That's so amazing. We haven't had any negative experiences really with patients. That's amazing, Gill. Thank you. And I think the next question, as we can all see on the screen, are the nurses already experienced in breast cancer management, or are they new to the disease? I think they're referring to nurses who come onto the program.
Yeah, so it's a bit varied actually, and that's why we try and make the program as individualised as possible. We're finding that most nurses coming into these metastatic roles more typically have a oncology background. Often they're breast care nurses previously, so I've looked after both early and metastatic patients, but more often than not, it's nurses who maybe had a day oncology background who come into the roles. So needing that breast cancer specific knowledge and skills.
Sure, thank you. And then the other question was about, I guess, sort of accreditation or credentialing and recognition by the university from this training perspective.
I'm happy to take that one too, Gil.
Sure.
Obviously, Monash University are a partner in this project, so they're very, very keen and interested in this mode of delivery for learning. So where we take this is still to be decided. And we are looking to have all of the modules, so the online learning modules, endorsed, CPD endorsed by the Australian College of Nursing, who we work very closely with in the education of our nurses otherwise too.
That's wonderful, Olivia. And I think we just have time for that very last question.
Sure.
And are we limited to just having 2 participants per intake due to the available technology? I think they're referring to the telepresence robots. Or are we thinking that there might be more robots, in the pipeline?
Sure. So I can answer this one. We actually have 2 robots because they have limited battery time. So the other one we've packed away because we're taking it to COSA next week. I've got Rosie next to me here. When we first were learning the capacity of these robots, we were excited to find out that we could have 6 people inside the robot. However, we soon found out that had limitations because the Wi-Fi didn't cope with it, or the bandwidth didn't cope with it. So we've just worked out that it copes a lot better just with one person. So we've designed the ongoing education program to have just one nurse in the robot and the other one in person as a result. But I really, just to also get everyone to think about, I see these robots have so much capabilities, or there's the potential to do ward rounds in distant areas for clinicians. They could be located in Melbourne, have a robot in Alice Springs, for example, and they could remotely see patients through the robot. You get a 180-degree view from the robot, and like I said, you've got full control of driving it, either from your keyboard on your laptop, or there's an app that you can have on your phone.
Thank you once again, Gil and Olivia. Such an amazing, initiative, and I think very exciting. And I'm sure that the rest of us who have heard your talk will be very eager to hear where this is going to go to, in the coming months to years. Now I'd like to then hand back to Andrew, who will introduce our next speaker. Thanks very much. Yeah.
Thanks, Siwan. And just to encourage people to please ask questions in Slido. We may not have time to cover all of the questions, but they will be able to be addressed later and posted online. So please feel free to ask as many questions as you would like. It's now my great pleasure to introduce Lisa Murnane, who is our second speaker today. Lisa is a senior clinical dietitian and nutrition support lead at the Alfred Hospital. She specialises in upper gastrointestinal surgery with a particular interest in the prevention, identification and treatment of malnutrition. Lisa is undertaking, and I think almost completed a PhD, which is focusing on the impact of body composition, specifically sarcopenia, on surgical outcomes and the nutritional consequences of oesophagogastric cancer surgery. As a recipient of a grant from the 2021 SMICS funding program, today Lisa will be presenting information from her project called NuBio Pathway. So welcome, Lisa, and thank you very much for joining us today.
Thank you, Andrew, and thank you to SMICS for the opportunity. Can I just check that you're seeing my whole slide and not presenter view? It's hard to tell on this screen. Yep, whole slide. Fantastic. Great. So this project was a collaboration between the Nutrition and Dietetics Department at Alfred Health, as well as the Department of Oesophagogastric and Bariatric Surgery. So I know that a lot of people would be aware that for patients who undergo oesophagogastric cancer treatment, their journey can be long and arduous and quite taxing, particularly when it comes to their ability to consume enough nutrients, which means that this may lead to the development of or worsening of malnutrition or poor muscle health throughout their treatment journey. And poor muscle health is a term that is, I guess, a newer concept in this patient cohort or in cancer in general, and it refers to low muscle mass and poor muscle quality. And it's been associated with worse oncological and surgical outcomes, so things like increased treatment toxicity and increased risk of postoperative complications for patients who proceed to surgery. And you can see here that in this diagram, it demonstrates that for patients who may present at diagnosis with low muscle mass after undertaking a catabolic stress like surgery, or whether that be their neoadjuvant treatment, they can be at risk of having severe muscle loss, which can increase their morbidity and mortality. Some previous work we've done at Alfred Health has shown that about 80% of our patients have abnormal muscularity, with about 60% having either low muscle mass and the same amount having poor muscle quality. And the overlap here showed that there are about 40% of our patients that had both low muscle mass and poor muscle quality. We wanted to also understand the changes that occur during neoadjuvant treatment, and we found that both body weight and skeletal muscle decrease from diagnosis to restaging, and also for the number of patients who were diagnosed with low skeletal muscle mass based on predefined cut points increases significantly throughout their neoadjuvant treatment. So the problem that we had was that we knew that malnutrition and poor muscle health impaired the patient's capacity to tolerate their treatment and also impacted their postoperative complications and poorer survival overall. But muscle mass and muscle strength wasn't being assessed routinely in clinical practice. It was really just done in the research setting. And so we found that without measuring patients' muscle mass, we were missing patients who were high risk of malnutrition or who were already malnourished, and we weren't picking them up at an earlier enough stage. We also have the situation like many metro centres where patients may have their neoadjuvant treatment in different settings. About 40% of our patients have their neoadjuvant treatment elsewhere. And so the surveillance of nutrition status and the dietary interventions for these patients can be quite variable. So we like to standardise a patient-centred and streamlined approach to delivering high-quality nutrition care in patients at high risk of malnutrition with oesophagogastric cancer. So the aim of the project was to develop a framework that involved the early identification of nutritionally high-risk patients and develop a standardised nutrition care pathway that could be provided to all treating healthcare services. Our first objective was to implement body composition assessment to identify poor muscularity and make that part of our routine MDM processes, and then to develop a way to communicate these results to the patients and also the clinicians, regardless of their geographic location. And finally, we wanted to develop a feasible and a sustainable pathway for treatment of high-risk patients that can be utilised at all healthcare services. So we included all patients who were diagnosed with esophagogastric carcinoma who were deemed eligible to undertake curative resection and had their surgery at Alfred Health. The health services included are listed there and included Cabrini Health, Peninsula Private and Public Hospital, Mildura Base, and any other private or rural hospital that patients had treatment during the pilot period. So in terms of how we conducted the project, we used the Plan, Do, Study, Act methodology. The planning phase was the most comprehensive. We did a literature review to assess the components that would be including in the pathway. But the main part of that was to identify a mechanism to accurately identify body composition using computed tomography images. So this involved stakeholder engagement and identifying experts in the area to determine the best way that we could use their CTs to identify body composition and implement that into practice. We also obtained ethics for this project as well. We then went live with the pilot for about 6 months and collected data along the way, and have since evaluated the project and have now implemented it into standard practice. So to address our first objective, the first step of that was to measure muscle mass and muscle quality using diagnostic and restaging CT imaging. So you can see there that we selected a software program whereby the series of the abdominal CT can be entered into the program, and it automatically identifies the third lumbar vertebra and the axial slice there, which has been validated to measure skeletal muscle mass at that level. So it's a cross-sectional area of muscle mass at that level. And then it generates a report there that you can see on the right-hand side. The second part of that objective was to incorporate this into the assessment of malnutrition. There's an overview there that describes how we would do that, and more recent definitions of malnutrition include low muscle mass. So we included that in our diagnostic tool for malnutrition as well. And then based on the patient's malnutrition diagnosis, that dictated their nutrition care plan thereafter. The second objective was to develop mechanisms to communicate these results to the clinicians and the patients. And the first thing we did there was include a summary of the patient's muscle results, so their low muscle mass or their poor muscle quality, as well as their BMI and their overall nutrition status. So that was included in the MDM agenda and also in the patient summary report that was included into their medical notes. The second part of this was a nutrition care summary that was sent out to clinicians to inform them of the patient's muscularity, their overall nutrition risk, and if they had had a diagnostic and restaging CT, we would describe the changes that have happened throughout that time as well. And the patients also received a summary, which we had stakeholder engagement to give feedback on the documents that were given to them. The third objective was to develop the nutrition care pathway, and this is a multi-page document that steps through each of the processes. Firstly was the CT body composition analysis that I've described. We then detailed the anthropometric and dietary assessment, the malnutrition diagnostic criteria that we chose, and then there was a resource that was developed specifically for the dietitians that went through the timing of the initial assessment. So for patients who are high risk, we were bringing that initial assessment forward to basically immediately after the MDM. We detailed the frequency of reviews, how to monitor body composition changes at the bedside, including things like calf circumference and hand grip strength, and various nutrition parameters throughout the care, so inpatient and post-operatively as well. So to summarise the care pathway, it started at diagnosis. At the first MDM, the body composition and nutrition status was identified. This was then communicated to the treating team. The patients went on to have their neoadjuvant therapy. We would repeat that process at their restaging MDM and then provide the information to the patient prior to their surgery, and obviously provide ongoing care after their surgery as well. So in terms of the project outcomes, we addressed our key performance indicators, which were to do with the assessment of body composition, which was not occurring in usual care. The fact that we were assessing skeletal muscle and strength throughout the treatment pathway increased significantly, as did the inclusion of nutrition parameters in all of the MDM documentation as well. And although the numbers weren't enough to look at statistical differences, we did find that there was an improvement in body weight between usual care and the pilot phase, and also the amount of muscle that was lost in that period as well, although we would need much larger numbers to look at any statistical significance for these particular parameters. In terms of the evaluation, we did consumer evaluation as well as clinicians, and for the consumers, they reported that it did improve their understanding of the importance of skeletal muscle, and it was particularly important for patients who felt that they may have needed to lose weight or perhaps a higher body weight. They really weren't aware of the implications of their weight loss, and so that was important for them. And from a clinician's perspective, it improved everybody's understanding of the importance of muscle health. They didn't consider the additional measurements that we were doing to be burdensome. There was strong agreement that this process should be continuing in standard care for all patients. So the clinical applicability of our project is that we've now provided timely nutrition interventions that can maintain or optimise nutrition status before surgery, and we're aiming for all patients to have individualised nutrition care based on their body composition, irrespective of their treatment location. And so we've been utilising novel biomarkers or body composition techniques to identify those that are high risk, aiming to ideally mitigate the risk of adverse surgical outcomes in the future. I'd just like to thank the collaborators on this project, particularly Paul Burton, upper GI surgeon at the Alfred, and our data manager and nurse practitioners as well. Thank you very much.
Awesome. Thank you very much for that, Lisa. We are running a little bit over time. We have time for a couple of questions, but probably won't be able to cover all the questions. There is a bit of an overlap. There's a couple of questions that are really asking similar things, but they're really looking at whether or not this project can be rolled out into other cancer types, for example, pancreatic cancer or other cancers where malnutrition and neoadjuvant treatment may be able to be targeted.
Yeah, absolutely. We intend to. So the dietitian or myself is doing the CT body composition analysis, and we plan to train other dietitians in the oncology space. So obviously we would let the surgeons or clinicians know working in that area, but there's no reason why we wouldn't be able to implement something similar. So at least we've got a baseline assessment of the patient's body composition at the start of their treatment.
Right. And how supportive were? Well, I think you've answered this, but I think most of the clinicians were pretty supportive. Yeah. I was interested in whether you could use PET scans to assess the muscle, but someone else is also asking about whether you could use ultrasound or other technologies. Do you really need to have a dedicated CT?
Yeah, you can do a PET CT. Can't just be PET. It have to be the CT component of the PET. Ultrasound can be used. It measures muscle thickness, but those protocols, I guess, are less well established, and there aren't sort of cut points to identify what is considered to be low muscle mass, particularly not in cancer patients. So I don't think the ultrasound is ready yet, really, from a accuracy perspective, just yet.
Right. All right. Look, in the interest of time, just one last question, just with regards to any challenges you had enrolling patients. I presume they were pretty happy to go on the study.
Very keen and liked hearing about their muscle and liked looking at their hand grip strength, and they were very enthusiastic.
All right. Okay. Well, as I said, we're running out of time, but I'd like to again thank Lisa for making the time and effort to come and join us on the forum today.
Thank you.
Really interesting presentation. I enjoyed that immensely. Thank you very much. And I will now move on to our third and final presenter. And I'd like to introduce Madlyn Connelly, who is the project lead for the Monash Health Altered Airway Quality Project, which has also been funded by SMICS. After graduating from La Trobe University with a Bachelor of Health Sciences and a Masters of Speech Pathology in 2013, Maddie has worked extensively across the continuum of care in both public and private health services. She has clinical expertise in the area of head and neck oncology, as well as her role in the current Altered Airways project. Madlyn has research interests in the impacts of radiotherapy on voice and laryngeal irritability. Welcome, Maddie, and again, thank you very much for joining us. Take it away.
Thank you, Andrew, and thank you everyone, and for SMICS again to have the opportunity to speak on behalf of our wonderful project team about our exciting project. So Monash Health Speech Pathology were fortunate enough to be successful in the SMICS Quality and Service Improvement funding for this project. We're just over halfway through the project at the moment, and the funding went towards funding the project lead role of 0.5, which I'm currently in. And the project is in essence a feasibility study to pilot a model of care for community-based management of patients with an altered airway, and the title there, Specialist Multimodal Speech Pathology Service for Head and Neck Oncology Patients with an Altered Airway, Implementation of Proactive and Preventative Community-Based Care via Telepractice. And before I continue, I'd also like to acknowledge the traditional custodians of the land on which I'm currently presenting on, which is the Wurundjeri and Boonwurrung people of the Kulin Nation, and extend that respect to any First Nations people here today as well. And just an acknowledgement here to our project team, as well as our wonderful group of consumer and regional health professionals that were really important in the project. So just a little bit of background, when we talk about people who have an altered airway, for those who are not aware, we're talking about people who have had a laryngectomy, which is the surgical removal of the voice box, and also a tracheostomy, which is the insertion of a breathing tube in the neck. So people with an altered airway will have changes in their communication, changes in their respiration and breathing, their swallowing, and they'll often require specialist lifelong speech pathology to optimise their respiratory health, their communication and swallow function, because an altered airway doesn't self-clean like our nose does, and it requires quite a high burden of care for the patient, high frequency care from them to maintain their breathing and voice. So we also know from our clinical experience and the literature that people with an altered airway experience psychosocial and functional disturbances related to their surgery, and these changes are often persistent, and they also have a higher burden of care, impacting their ability to participate in occupational and social activities, and also impacts on their relationships with others. Because of the vulnerability of and complexity of this population, they also have high rates of readmission to hospital or extended length of stay in hospital. And so Monash Health Service is the largest cohort of oncology patients with an altered airway in Victoria, and we actively service, in 2021 we were servicing almost 100 patients, and there were 93 admissions in 2020 for these patients related directly to their altered airway. We also service patients living in a large geographical area as well, so just around 20% of our patients are living in regional and remote areas. We currently provide our speech pathology services largely based at our interdisciplinary oncology clinic, which is at Moorabbin Hospital in metropolitan Melbourne. And there's a lack of specialised community-based care, placing pressures on our clinics and limiting our patients' ability to access functional and person-centred rehabilitation. And so we proposed a trial of multimodal approach, which is our standard on-site care alongside telehealth sessions. We aim to see if providing this service would improve access, engagement and satisfaction for our patients, as well as if it would reduce readmissions and length of stay to hospital. So just a really brief summary around our project method. So we wanted to design a pilot model of care that met the specific needs of our cohort. And so we completed a retrospective file audit, as well as distributed patient and carer surveys, and collaborated with our dedicated consumer advisory group, which I'll talk a little bit more about in a second. We're currently in the implementation phase of providing this service, and we will then be collecting our post-pilot data and completing analysis to be able to report on the sustainability of this model of care for the future. Another part of the project is upskilling and collaborating regional clinicians, but today I'm just going to focus on our file audits and patient surveys, speak about the role of our consumer groups, and share some preliminary results from our interventions. So some of the preliminary data from our file audit and patient and carer surveys were that we found that people who are managed at Monash Health with an altered airway on average were readmitted at least once during that first 12 months after their surgery. around a third of patients rated their confidence at being able to manage their own airway at moderate or below in that first 6 months after surgery. And 50% of patient carers reported high levels of stress post-operatively in that first 6 months after surgery. That actually increased to 75% of carers reporting stress at the time of surgery. And some of those carers were reporting that years and years after the person's surgery. So, you know, that persistence in terms of the impact. On average, our consumers travelled 320 kilometres just in the first 3 months after they were discharged from hospital to attend the outpatient appointments at Monash. And we saw that travel didn't just impact our regional patients. So 41% of our consumers reported travel as a barrier to accessing speech pathology. And so alongside this data that we collected, ongoing collaboration with our consumers was really important as it informed the design and implementation of our pilot. So we had a dedicated and wonderful consumer advisory group that you can see some of the members here, and that included people who have lived experience, so people who have an altered airway and also their family members. And they consulted on major aspects of the project. They were involved with the content for learning resources that we created for health professionals, advising on patient engagement challenges we were experiencing, and also, of course, helping to shape the design of the model of care, which I want to talk about now. So the model of care is novel and accessible and utilises video and phone calls to extend our standard on-site care. The design of this model offers more or less frequent appointments depending on the person's situation. So for example, more frequent contact during the adjustment phase after their surgery, you know, in that first sort of 6 to 12 months, or for people who have minimal social supports, and less frequent contact for longer term patients who are independent and well supported in the community. So we have 15 patients that have gone through the project so far, and 44 occasions of service so far as we go through this implementation phase. And the sessions are varied as they're patient-centred and they really depend on the patient's goals. But for example, we have been providing voice therapy to a patient who lives in a regional area via video, in working in collaboration with his local speech pathology service to improve his confidence to be able to order fish and chips at the local shop, which is one of his goals. We're supporting a patient in the return to work process, and again, working collaboratively with his NDIS support worker by videoing into sessions to break down complex and overwhelming job applications into more achievable tasks to minimise his frustration. And we've also been able to support a patient with a tracheostomy to get home for end-of-life care. So that consisted of he was receiving home-based speech pathology, and we were able to video into that call those sessions to provide that specialist clinical recommendations related to cleaning and safety of the airway, providing oral health and swallowing recommendations, as well as counselling techniques of listening and reassurance as the patient's symptoms progress towards the end of their life. And so whilst we're still implementing the pilot model of care, I do want to just share some of the impacts that we've seen for consumers that have gone through the service already. So just some quotes that I'd like to share, and that first one on the top left is the wife of the person that we were able to support through the end of life. And I'll just leave you a few seconds to have a read of those. So certainly something that we see is that many of our patients report that they wouldn't have accessed speech pathology, they wouldn't have actually done any of the rehabilitation or any of that if it was on-site only. And now the moment of truth to see if this video works. So this is Ron, who lives in regional Victoria. Before the project, he absolutely did not want to use telehealth because he'd actually unfortunately lost his voice completely due to complications after his surgery. So his local speech pathologist had gone on maternity leave and they hadn't been able to replace any local speech pathologist, so he had no access to speech pathology at that time. We were able to upskill him in using telehealth as well as providing communication therapy to use the electrolarynx device you'll see here. So very generous of Ron to share his thoughts there. And so just lastly, we are finishing the implementation of the pilot at the end of this year. We'll then be analysing the data to design a sustainable service that we can provide ongoing as part of our speech pathology service at Monash. We look forward to being able to share the outcomes of the projects in the new year with you, and thank you again to SMICS for providing the opportunity for us to complete this really valuable project. And just some references there. Thank you, everyone.
Awesome. Thanks very much, Madlyn. That's sounds like a really important project, helping a lot of people by the sounds of things. I had a question. I was just wondering, what do you find difficult to do as a speech pathologist via telehealth? Are there actually limitations to the service you can provide as opposed to, you know, someone actually coming face to face in the clinic?
Yeah, thanks, Andrew. I think in this particular cohort, you know, absolutely there are things that work really well over telehealth and then things that are more challenging. There is literature in the space around how effective and how accurate assessment of altered airway patients is over telehealth that's been done in the past. And certainly we find, you know, things that mirror that previous literature, which is that visualization of people's stomas, the really nitty-gritty things is really challenging to assess, and therefore that's why it was really important that this didn't replace our standard care. So patients will still be coming in to see the speech pathologists in the usual way, and of course if we identify things on telehealth that we're not able to adequately assess or you know, we have concerns about, then you know, we get patients to come in and see us or facilitate them being seen by local speech pathologists, you know, working around that. So really important that it doesn't replace on-site face-to-face care, but things like problem solving, supportive, you know, counselling aspects, as well as therapy such as voice therapy, communication therapy, those things work really well over telehealth.
Great, thank you. A couple of questions from the audience. Firstly, were the First Nations people represented in this model?
Thank you. Yeah, so what we've looked at is we absolutely have several First Nations people in our cohort of consumers, and we had one patient who was with a First Nation, who is a First Nations person who was keen to be part of the project. In terms of actually being able to engage that person, you know, understandably we've had challenges, and so working around things like working with their Aboriginal liaison officer, working with the local speech pathologist that lives, because they live actually up towards the border of New South Wales, has been things that we've tried. And I guess in terms of it being a feasibility study, what we will be looking at the end is what were some of the challenges and barriers that we came up against. And also from the patient as well. So the patient was part of the surveys and also will be part of the post-pilot evaluation to work out what things we can do in the future to engage and support people who are First Nations people, but also people who are non-English speaking. You know, we have a few patients who we've utilised interpreters and things like that, but again, it's been challenging, you know, so looking at what things we need to do in the future to make this more equitable.
Great, thank you. And time for one last quick question. Yeah. So have the regional services that patients are accessing, have they actually needed additional training or support, have you found?
Yeah, so another part of the project that I didn't focus on just in the interest of time is we did surveys to speech pathologists, nurses and doctors working in regional centres in terms of their skill and knowledge and confidence around working with people with an altered airway and what barriers they identified. From there, we created a regional focus group, which are a group of nurses and speech pathologists who've helped us at certain decisions as we go through the project and help to champion the project and the engagement at their local networks, and also created a suite of we've done it live via Zoom, and eventually we'll be able to provide this as an ongoing self-directed learning modules for working with people with an altered airway. So they absolutely do want the additional support and training. We had 62 registrants for the first round of our education session, so they really do want the resources and the support, and it's just about working with them to make sure that it addresses what they are needing.
Great, thank you, and thanks again for an awesome presentation and taking the time to join us.
Thank you.
That's almost the end of the forum. I'm just going to hand back to Ziwan to wrap up.
Thanks very much, Andrew. And before we wrap up, we do have an evaluation question on the poll question for the audience. If you could provide us with your response, that will be much appreciated. And we do acknowledge we don't have the time in the very tight program to actually answer every question on Slido, but we will seek responses from our guest speakers to any of the unanswered questions and upload these on the SMICS website. If there are any other questions or you want to know more about any of the projects highlighted in today's forum, we will shortly provide contact details for you to get in touch with us. Finally, I'd like to give again special thanks to our presenters today, Lisa, Olivia, Gill, and Maddie, and really congratulations to you all for your fabulous and wonderful initiative. I'd also like to thank the Monash Comms team, Natasha, Nick from this event, SMICS team, particularly Nell and Selena, Felicity for opening the forum, and everyone else who's been involved directly or indirectly, for the work behind the scenes to make this forum possible. And of course, finally, thank you to all of the audience for your attendance today and your participation, especially also with the questions on Slido. And as Felicity mentioned earlier, we look forward to a face-to-face forum from next year where we can get together in person. And before I finish, I'd just like to have a look at the responses to the evaluation. And do we have the results on Slido? And no. Sorry about that. And on behalf of Andrew, my co-host, we'd like to thank you once again for your attendance and have a good afternoon. Thank you.